Good morning and happy Sunday. This is Nurse Eunice with Florida Training Academy. And in today's video, we're going to be covering ACLS prep, the shockable rhythms. And we'll give you about 10 seconds to receive your notifications. And we'll see you shortly. All right, so welcome in introduction. Welcome to the ACLS review and practice test, where we focus on preparing you for success in advanced cardiovascular life support. In this session, we'll review critical concepts, including identifying shockable rhythms like ventricular fibrillation and pulseless ventricular tachycardia, and the steps to manage them effectively. So whether you're renewing your certification or preparing for the first time, this comprehensive review will boost your confidence and help you save lives. And so if you haven't done so already, I am going to ask that you go ahead and get pen and paper so that you can take notes during this presentation. The first half will be our review, and then the last portion will be our practice test. And so I won't be monitoring the chats until it is time for the practice test to begin. If you need more help with your algorithms or running a code, we have a playlist on YouTube that is our ACLS Mega Code review. And you can find that playlist by going to youtube.com/Florida spelled out training. All right, so introduction. Our shockable rhythms in ACLS, that is advanced cardiovascular life support. Those are life-threatening conditions that require immediate recognition and intervention. So the two primary shockable rhythms are pulseless ventricular tachycardia, which we refer to as VTAC, and also ventricular fibrillation, which is VF. And on the image, you're going to see a strip, and this represents VF. It is a regular chaotic ECG waveform with no identifiable P waves, QRS complexes, or T waves. It's just quivering. Whenever you assess your patients, there will be an absence of a palpable pulse. And of course, the patient's going to be unresponsive and they're going to be apneic, meaning that they're not breathing. Ventricular fibrillation, or VFib, is a life-threatening cardiac arrhythmia characterized again by the rapid, chaotic, and uncoordinated electrical activity in the ventricles or the lower chambers of the heart. Whenever a patient has VFib or VF, it prevents the heart from effectively pumping blood, leading to sudden loss of cardiac output and potentially causing cardiac arrest. So when you see this on the monitor, you're immediately thinking BLS. Is my patient responding? Do they have a pulse? Are they breathing? You want to be doing that assessment within 10 seconds and calling a code, calling for help if your patient's pulseless. VF often occurs as a result of underlying heart conditions, such as coronary artery disease or after a heart attack. It requires immediate medical intervention, typically through defibrillation. We're going to use electricity and electrical shock in order to get the heart back into a perfusing rhythm. And so we use the defibrillator to restore a normal heart rate along with CPR to maintain blood circulation until the defibrillator is available. Another shockable rhythm that we will be discussing, so we just talked about VF or VFib. That was the chaotic, unorganized, no identifiable P wave, QRX complex, etc. The next we're going to go to is pulseless ventricular tachycardia. Notice that I used the word pulseless because a patient can have ventricular tachycardia and they can still be talking to you. They can still be conscious. So you're always thinking again of your BLS assessment. Anytime there's a change in a rhythm, we don't treat monitors, we treat humans. So if there's a rhythm change, you go and you tap and you shout if that person's not talking to you, and you start feeling for that carotid pulse. So, pulseless ventricular tachycardia is a life-threatening arrhythmia where the heart's ventricles beat rapidly and abnormally, but do not generate an effective pulse or blood flow. So, there is no pulse. This results in cardiac arrest and the inability of the heart to supply oxygenated blood to the body. Pulseless VTAC often occurs due to underlying heart rhythms such as myocardial infarction. The heart muscle has died, it is damaged, electrolyte imbalances, or cardiac trauma. Now, I want you to keep those electrolyte imbalances in mind as I go to the next slide, because this is also a type of ventricular tachycardia. It is referred to as Torsades de Pointes. This is the twisting or the spiraling QRX complex pattern, and this is most likely caused due to a lack in magnesium. So yes, we're going to be talking about shocking the patients, etc. But if you see this wide and bizarre QRX complex that is twisting, you're going to have to also include magnesium sulfate in your cardiac arrest algorithm. And that's one of the first statements I have there, that magnesium sulfate is particularly effective for Torsades associated with prolonged QT intervals. You want to administer that medication slowly when it's not in a cold situation. But if this person is actually in cardiac arrest, you can push the medication a bit faster, over 1 to 2 minutes, since perfusion is critical, getting the heart restored so that the heart can now circulate the organs on its own and you can stop your chest compressions. So whether a patient has VF, that's ventricular fibrillation, or pulseless ventricular tachycardia, their signs and symptoms are going to be similar. You will have a disorganized rhythm on the monitor. If it's going to be pulseless VTAC, it's going to be a rapid, wide, complex rhythm, but either way, your patient will not have a pulse. They will not be conscious. They won't be talking to you. If you attempted to get a blood pressure, you're not going to be able to. You won't hear anything because there's no blood flowing in the arteries. And the patient could be cyanotic, or definitely they're in respiratory arrest, because if the heart stops, of course, they're also going to stop breathing. Going back to the BLS survey, I teach a lot of ACLS classes, the advanced classes, and I find that some people are so focused on what medications to give that they forget that if the BLS team, if the basic part of life support is done ineffectively, you're pushing medications that are just simply sitting in an IV catheter. So what do I mean by that? Whenever you come upon a patient who is unresponsive and you tap and you shout and you feel for the carotid pulse and check for breathing simultaneously for 10 seconds, you call your team as soon as you recognize that this patient is unresponsive. You have to start high quality CPR. So those chest compressions, what rate are we referring to and what depth? So the rate will be 100 up to 120 compressions per minute. The depth for an adult is 2 to 2.4 inches. But if you have a larger patient, you're going to be compressing deeper. So it's okay to do 1/3 of the anterior posterior, the side view of the chest, because the larger they are, the deeper you're going to have to compress. And if you have your bag mask device there, you're going to be alternating. After 30 compressions, you're going to be giving 2 breaths. If you don't have any equipment yet because your team hasn't arrived with a crash cart, you're just going to continue doing those high quality CPR, high quality compressions nonstop until the team arrives with the additional equipment that is needed. And now when the AED arrives, we will use that also. All right, so let's talk about those reversible causes. So we reviewed the BLS survey, the reversible causes. Again, if you want to see a video of me using the ECG simulator and breaking down each of these rhythms, we have that on our YouTube channel under the playlist for the ACLS mega code. But why did this patient go into arrest to begin with? That's what we refer to the H's and the T's. The H's and T's are essential for identifying and correcting the root cause of cardiac arrest during ACLS protocols. Early recognition and targeted treatment can significantly improve the likelihood of return of spontaneous circulation. We refer to that as ROSC, and survival. So your job with BLS, your job with ACLS, your goal is to allow or help this patient to achieve ROSC. That means that the heart is now beating again on its own, aka the return of spontaneous circulation. So some of the reversible causes are going to be hypoxia, hypovolemia, hydrogen ion imbalance, aka acidosis, hyper or hypokalemia, and hypothermia. And we will break down each of these in the upcoming slides. The T's that I want you to consider are toxins. Let's say the person overdosed. Tamponade, referring to the heart. Tension pneumothorax, and also thrombosis. And that thrombus could be coronary or it could be pulmonary. So what does that mean? When we say hypoxia, I hope you have your pen and your paper available. So hypoxia is the insufficient oxygen in the blood that can cause cardiac arrest. And so how do we prevent hypoxia? Remember, we're trying to reverse this person's death. How do we reverse it? With hypoxia, we're going to ensure adequate ventilation and oxygenation. Maybe they need an advanced airway because their airway isn't patent. We're going to use supplemental oxygen and advanced airway management if needed. And so if we end up intubating the patient, then of course, if we have ROSC, we would put them on the vent and give their lungs time to heal. So that would be the treatment if we think that the cause of their arrest was due to hypoxia. Hypovolemia would be another potential cause of arrest. And so maybe this person was severely dehydrated, or maybe they were injured and they sustained a lot of blood loss. So hypovolemia can occur due to severe blood or fluid loss that reduces the cardiac output. How do we treat it? Management, we're going to administer IV fluids or blood products as necessary to restore circulation. So hypovolemia, immediately start thinking fluids and or blood. Hydrogen ion acidosis. If someone is acidotic, we need to get their pH balance back to normal. So we're going to do the opposite. We're going to give them a base. So this could be metabolic or respiratory acidosis. And the management, we're going to confirm with blood gas analysis and treat with ventilation if it's respiratory acidosis, or we're going to give them sodium bicarbonate for severe metabolic acidosis. So remember, if they're acidic, we're going to give them something to get rid of all of those acids within their body. Hypo/hyperkalemia, referring to the potassium level. So potassium imbalance can cause arrhythmias or arrest. So too much is a bad thing, too little is a bad thing. So we have to keep it within a certain range. For hypokalemia, we're, of course, going to administer potassium. But notice it says cautiously, because just like with magnesium sulfate, if we give too much of a good thing too fast, we can cause them to go into arrest. We can have them re-arrest later. For hyperkalemia, meaning that their potassium levels were too high, we have to get rid of some of that potassium. And of course, this is during the code, so we can't take them to dialysis. So what are we going to do? We're going to administer calcium chloride or gluconate. We can also give insulin with glucose that would pull the potassium, and also consider bicarbonate. And once the person is stable, then we can consider dialysis. Another H is hypothermia. So the body temperature is lower than normal. So why would this happen? Maybe the person drowned. All right, so for a core body temperature below 35 degrees Celsius or 95 degrees Fahrenheit, it impairs cardiac function. So we're going to use a warming blanket. One of the common ones is called a bear hugger to gradually rewarm the patient, and of course continue our resuscitation efforts until the patient is normothermic, meaning that they have a normal temperature. Let's get to the T's, team. So, tension pneumothorax. What does that mean? Air is trapped in the pleural space and it compresses the heart and the lungs. So, how do we get this air out of the pleural space? We're going to do needle decompression. So, yes, the doctor will insert a needle and also followed by a chest tube placement. So, this person, we need to go ahead and remove some of that excess air in the pleural space. And so, that chest tube is going to help normalize the pressures within the chest cavity. Cardiac tamponade. Tamponade is the fluid accumulation in a pericardial sac. So the sac surrounding the heart, and it prevents the heart from contracting effectively. So imagine something just squishing the heart. All right, so how are we going to remove that fluid from the pericardial sac? Similar to what we would do for a tension pneumothorax, we're going to do some type of pericardiocentesis, or we're going to use a needle to relieve the pressure. So again, it's too much swelling. We're going to have to remove that swelling and that excess fluid. Our next T is toxins. Let's say someone used an illegal drug. So drug overdose or poisoning can cause cardiac arrest. The management, we're going to identify and administer antidotes as available. So one common antidote for opioids is naloxone or Narcan. Again, that's used for opioid overdoses. So if we suspect that a patient came in and they OD'd on something, part of the drugs that we're going to be giving them during the code would consist of Narcan. And we're also going to support circulation with those advanced measures as needed. Pulmonary thrombosis, a clot that has traveled to the lungs. So a pulmonary embolism blocks blood flow to the lungs. And during the code, there's not much we can do about this, but we're thinking about what caused this person to arrest so that whenever we restore their heart rhythm, we know that we're going to have to administer thrombolytics. That's something that's going to break up the clot, a clot buster. If the doctor needs to go in and perform a surgical embolectomy, that means they're going to remove the embolus. And then we're going to start anticoagulation therapy. More than likely, this patient is going to be on blood thinners for life. Similar with cardiac thrombosis. So that embolus traveled to the heart and it caused a myocardial infarction because it blocked the major coronary artery. And so what would be the treatment once we achieve ROSC? We're going to have reperfusion therapy. This patient's going to be sent to the cath lab for a percutaneous coronary intervention, such as a stent, or maybe they need a more severe surgery. Maybe they need open heart surgery. They need a CABG, and they too will be placed on blood thinners as indicated. Let me take a sip of water. I apologize. So whether we have ventricular fibrillation or pulseless ventricular tachycardia, your treatments are going to be the same. We're going to immediately start CPR. Once that defibrillator comes in, if we have an AED, it's preset to whatever that make and that model's energy setting is. But in your hospitals, most of your defibrillators, the manual defibrillators on top of your crash cart are going to be biphasic. And so you can start off with up to 120 joules, and you can increase the joules or stack them each time you have to give a subsequent shock. So maybe start at 120, then go to 150, and if a third shock is required, then you go to 200. The first drug we're going to administer is going to be epinephrine. And so the dose for epinephrine is 1 milligram IV or IO. That means intraosseous or intravenous every 3 to 5 minutes. So a good rule of thumb is you give epi every other cycle. So epi is the first cycle, third cycle, fifth cycle. What are we doing in between when we're not giving epi? Well, we can give amiodarone. And so I know it's going to sound bad, but I want you to think of it this way. The first dose of amiodarone has to be the high dose. So the way I remember it is amiodarone, the first dose is the dead man's dose. I have to give 300 milligrams IV. I'm going to give that higher dose the first time. So first cycle, epi. Second cycle, amio 300 milligrams. Third cycle, epi. Fourth cycle would be amio 150 milligrams. And we're going to cycle out compressors every 2 minutes and also reassess the need for continued CPR and more shocks every 2 minutes. We reassess and we switch every 2 minutes, remembering to minimize interruptions to no longer than 10 seconds. I love the ACLS algorithm, the circular algorithm. It just simplifies everything for me. If you want to download your copy along with our study guide, you will go to our website, which is fltraining.com, go to the resources tab, and then click on study guides and more for your ACLS exam prep study guide and materials. But the blue line that goes around, the dark blue line, the circle, that represents 2 minutes of continuous CPR, high quality CPR. If initially we find that a person has a shockable rhythm, CPR is in progress, you determine the joules. So let's say you want to give 120 joules. You'll make sure you charge the machine. You clear everybody before you press that shock button. And once the shock is initiated, you go right back into your high quality CPR. 30 compressions followed by 2 breaths, utilizing a bag mask device. If the patient already has an IV, you can start epi during this cycle. But if they don't have an IV, this cycle would be useful for the actual initiation of the IV. If you're unable to get an IV, if your best nurse can't get an IV within about 2 sticks, 45 seconds, you need to go to IO. You need to start drilling in the bone because we have to give a medication, at least in our second cycle, if we're unable to give any medications in our first cycle. At the end of 2 minutes, you would be switching your compressors. We would recheck the pulse, recheck the rhythm, and within 10 seconds, get back on that chest. If this person is still in a cardiac arrest rhythm, get back on that chest, prepare that machine. It's going to be time to shock again. And now you determine if you're going to give 120 joules again, or if you want to start stacking and increasing the dose of the joules. All right, so let's do another quick review before we start our test. So for your ACLS shockable rhythms, our general nursing interventions, what I need my nurses to know is that for your chest compressions, as I mentioned before, if you can't do BLS, it doesn't matter if you know what drugs to give. We need to make sure those compressions are effective. So you're going to maintain a rate of 100 up to 120 compressions per minute at a depth of 2 to 2.4 inches. Defibrillation safety, when I'm teaching you all in the classroom setting, a lot of you all do not clear head to toe. You have to clear the bed. You have to make sure no one's touching. Otherwise, you're going to shock one of your coworkers. And we have to call another rapid response team in for them. So ensure no one is in contact with the patient during shock delivery, but that immediately once the shock has been given, we go right back into those high quality chest compressions. Medication administration. We cannot give a medicine if we don't have an IV access or an IO access. So get it as soon as possible and confirm that if they came in with the IV already, or maybe when you arrived to the room, they had an IV, actually make sure that IV is patent before we start pushing these medications. Communication. Use closed loop communication. In other words, when the team leader gives you an order, you repeat it back to make sure that you have the right order. Or let's say that the team leader doesn't realize that you're a CNA and not a nurse, and the team leader tells you to draw up a medication. You would have to let him or her know that I'm the CNA, I can do compressions. So it's not that you get out of the code, it's just that you have to be mindful of your scope of practice, even if the team leader is unaware of, your scope. Because in the end of the day, if we all have on PPE, your badge is covered. So that team lead doesn't know if you're the respiratory therapist, the nurse, or the CNA. So make sure you inform him or her. And as I mentioned before, we're going to minimize pauses. You're going to take your hands off of the chest for no longer than 10 seconds. So we don't care what happens. Your patient vomits, you turn their head, you suction their mouth, and you get right back on that chest within 10 seconds because we have to keep blood flowing to the brain. That is your priority. Whenever someone's in cardiac arrest, your priority is CAB, circulation, those high quality chest compressions. And then your team members take care of the airway and the breathing. So just keep compressing until your team arrives. All right, so after we have done a great job and our patient has achieved a ROSC, our post-resuscitation care, you're going to monitor for the return of ROSC. Do they have a pulse? Yes, great job. Are they breathing? If they're not breathing, you're going to be having to think about, wow, we need to intubate this person. And then you will try to figure out the reason that this person has stopped breathing. So return of ROSC, just because they have a pulse, it doesn't mean they're breathing. So you want to be doing your additional assessments. You're going to prepare for therapeutic hypothermia. It allows the brain to rest. So after a person's gone into cardiac arrest, unless it's contraindicated, we're going to use a cooling blanket to cool them down to 32 to 36 degrees Celsius for 24 hours to give their brain time to rest. And hopefully they will have less neurologic damage. And as I mentioned previously, we're going to ensure that advanced airway is placed if needed, and we're going to continuously monitor them, and they should be in the ICU at this point. So early defibrillation is a cornerstone of survival in shockable rhythms, so you shock. So for VFib, you defib, you shock. For pulseless VTAC, you shock. You want to defibrillate. High quality CPR, timely administration of medications, and adherence to the ACLS protocol significantly improve outcomes. And nursing, the whole nursing team plays a vital role in recognizing these rhythms, initiating interventions, and coordinating team efforts during cardiac arrest. In some of these facilities, especially if you're interested in being a travel nurse or an agency nurse, some of those other nurses may not be as strong as you are. So you can't always wait for the doctor to come in to be the team lead. You're going to be the team lead until somebody with more experience comes in to relieve you. All right, team, let's get ready for our quiz. And so I'll start checking the chats in a few moments. Let me take another sip of water. And thank you all for studying with me bright and early on a Sunday morning. We're going to be doing more ACLS prep videos. I will do those on my personal channel, Eunice Mathis, instead of Florida Training Academy channel from here on out. All right, so here we go, team. Question number 1. What is the primary treatment for ventricular fibrillation, or VF? Is it amiodarone administration, chest compressions only, immediate defibrillation, or administration of oxygen? All right, revealing the answer in 5, 4, 3, 2, and remember that we defib for VFib. So the answer is C. Immediate defibrillation is the treatment of choice for VF to restore viable cardiac rhythm. Question number 2. Which of the following is a contraindication for intraosseous IO access? Is it A, severe shock, B, fracture in the target bone, C, cardiac arrest, or D, lack of IV access? All right, let us check the answer. It is B. So IO access should not be attempted in bones with fractures due to risk of extravasation. Don't forget that we're also not going to use a leg that is edematous or if it appears to have cellulitis. If we know the person has a history of bone cancer or bone infection, that would not be the extremity that we're using in order to administer medications via the intraosseous route. Question number 3. What rhythm is characterized by a chaotic, irregular waveform with no P waves, QRX complexes, or T waves? So which of those rhythms had no discernible complexes? Is it a systole, pulseless ventricular pulseless VTAC, Is it ventricular fibrillation or sinus tachycardia? Chaotic, irregular waveforms. Revealing the answer in 3, 2, and if you said VFib, you are right. So the answer is C. So VF shows a chaotic and irregular waveform with no organized electrical activity. Question number 4. Everyone should get this one. What is the recommended chest compression depth during CPR for adults? Is it 1 to 1.5 inches, 1.5 to 2 inches, 2 to 2.4 inches, or 3 inches? A, B, C, or D? All right, revealing the answer in 3, 2, and yes, you all have it. It is C. So high quality compressions require a depth of 2 to 2.4 inches to ensure effective circulation. Question number 5. Which medication is given during cardiac arrest for its vasoconstrictive properties? Is it amiodarone, lidocaine, atropine, or epinephrine? Think about the drugs that we mentioned during this presentation. All right, revealing the answer in 3, 2, and it is epinephrine. It is D. So epinephrine is a vasoconstrictor that helps to improve perfusion during cardiac arrest. And so epi is usually your go-to drug, your ACLS drug, whether the rhythm is shockable or non-shockable. Epi is the first drug administered. Question number 6. When using a defibrillator, what is a critical safety measure? A, ensure no one is touching the patient during shock delivery. B, apply gel to the defibrillator pads. C, administer oxygen while delivering the shock. Or D, perform compressions during shock delivery. What is a critical safety measure? We have to keep our teammates safe. So revealing the answer in 3, 2, and yes, you have it. It is A. We're going to ensure that no one is touching. That way we don't accidentally injure our coworkers or ourselves during shock delivery. Question number 7. What is the primary goal of post-resuscitation care? So once a person has achieved ROSC, why do we still keep caring for them? Is it A, immediate discharge home, B, monitor for ROSC and prevent rearrest, C, withhold advanced airway placement, or D, administer large volumes of fluids? All right, revealing the answer in 3, 2, and our goal for post-resuscitation care is going to be B. We want to make sure that this patient doesn't go back into cardiac arrest. So post-resuscitation care focuses on stabilizing the patient and preventing rearrest while addressing the underlying cause. Question number 8. How often should rhythm checks occur during CPR? Is it every minute, every 1 minute, that was a typo, every 2 minutes, or every 3 minutes? How often should a rhythm check occur? All right, and this one is super easy. So revealing the answer in 3, 2, and yes, it is C. So we're going to recheck that rhythm every 2 minutes. So whenever the compressor switches, they have 10 seconds to switch. That's when no hands are on the chest, and your team members can actually look at the EKG, the heart monitor, telemetry monitor, without any interruptions or any interference from those chest compressions. So they have 10 seconds to look at that rhythm. And so again, if you need to actually review the ACLS algorithm, actually look at a longer video that shows me running a code using an ECG, you can go to our website, fltraining.com. You can also go to our playlist on YouTube. Let's go to the next question. Question number 8. Which of the following describes team dynamics in a resuscitation scenario? A, assigning one team leader and clearly defined roles. B, allowing all team members to make decisions. C, rotating team leadership frequently. Or D, avoiding communication to prevent confusion. This one's tricky. What best describes the team dynamics in a resuscitation scenario? All right, revealing the answer in 5, 4, 3, 2, and yes, there has to be a designated team leader. So the answer is A. Effective resuscitation requires one team leader and clear role assignments for optimum performance. So we have a multidisciplinary rescue team. We have physicians, we have nurses. And let's say it's a new physician. I've been there before where there's a new doctor who doesn't feel comfortable running the code. The nurses will respectfully run the code with the doctor being there. So at that time, it's not about title. It's about who's best fit to help save this patient's life. All right, question 10. What should be done if ROSC is achieved after defibrillation? So great job. We have a pulse. Is it A, stop all medications immediately? B, reduce ventilation to 2 breaths per minute? C, discontinue advanced airway management? Or D, monitor blood pressure and oxygen saturation? All right, I'll give you about 5 seconds and then we'll reveal the answer. So 3, 2, and for this one, we are going to be monitoring that blood pressure. We have to make sure the patient remains stable or that we actually stabilize them. So the answer is going to be D. After ROSC, it is crucial to monitor hemodynamic status and oxygenation to maintain stability. So if we don't monitor them after we get their heart back beating, they could actually rearrest. And so we're going to make sure we order labs, chest x-rays. We're going to review those H's and T's. We're going to try to find the cause of that arrest and start treating it immediately so that this person has a better chance at survival. Survival is not just achieving ROSC. Survival is you making it out of the hospital at the same level, if not better, than you were before you came. So we don't want people to leave in a vegetative state. Question 11, which medication is used to treat persistent ventricular tachycardia that is unresponsive to defibrillation? Now, this should be easy because we only discussed 3 medications. So is it atropine, amiodarone, dopamine, or adenosine? There were 3 medicines that we discussed for shockable cardiac arrest rhythms. That was epi, amiodarone, and also magnesium sulfate. All right, so process of elimination, that means the answer to question 11 must be amiodarone. It is B. So amiodarone is the preferred antiarrhythmic drug for treating ventricular tachycardia. So remember, it's epi, then the dead man dose of amiodarone, and then it's epi, and then we give half the dose of amiodarone. So those are the 2 initial cardiac arrest or ACLS drugs for shockable rhythms. Question 12. What is the purpose of closed loop communication during resuscitation? A, to reduce interruptions during chest compressions. B, to show who's in control. C, to minimize the number of team members speaking. D, to confirm that tasks are understood and completed. All right, revealing the answer in 3, 2, and yes, the answer is D. Closed loop communication ensures clarity and verifies that tasks are completed correctly. Question 13. During CPR, what is the correct compression to ventilation ratio for a patient without an advanced airway? Is it 15:2, 20:2, 30:2, or continuous compressions with 1 breath every 6 seconds? And if you're in the Jacksonville, Florida area, and you're interested in becoming an ACLS provider or an ACLS instructor, we do offer those at Florida Training Academy. And again, the website is fltraining.com. All right, so let's reveal the answer. It is 30-2. Great job, team. So when someone is not intubated, if they do not have a tracheostomy, you're going to be giving 30 compressions followed by 2 breaths. Your team member using a back mask device will deliver the 2 breaths. But if a person is intubated, let's say that you're working today in the ICU and your patient who is intubated, they went into cardiac arrest. Well, you would disconnect the ET tube from the vent. And usually respiratory therapists, while you're doing continuous chest compressions, the respiratory therapist would give 1 breath every 6 seconds. So when someone is intubated, there is no ratio. It's continuous compressions. And for adults, we give 1 breath every 6 seconds, which means they're getting 10 breaths per minute. Question 14, what should be the first intervention for a patient in asystole? Asystole is the flat line. This person is gone. What is your first intervention? Is it A, administer epinephrine, B, begin chest compressions, C, defibrillate immediately, or D, administer amiodarone? Revealing the answer in 5, 4, 3, 2, and whenever someone is in asystole, when they have a flat line, we're going to be doing those chest compressions right away. Of course, you've called for your team. So chest compressions are the priority when someone's in asystole. Remember, asystole is not a shockable rhythm. It is not one of the rhythms we discussed earlier. So you cannot defibrillate. You cannot shock something that's not there. Remember, when we use the defibrillator, we're trying to reorganize the heart's rhythm. With asystole, it's a flat line. There is no rhythm. So you're just going to end up doing your high quality CPR, giving epinephrine, and trying to get to those H's and T's as fast as possible. Question 15, which of the following is an appropriate action during defibrillation? And let me reread that. Which of the following is an appropriate action during defibrillation? A, clear the area and confirm no one is touching the patient. B, ensure oxygen is flowing directly across the chest. C, ensure a shock while compressions are ongoing. Or D, use adult pads on pediatric patients without adjustment. Right, and everyone should get this right because we are safe caregivers. The correct answer is A. We're going to make sure that we clear the area to make sure that we do not shock anyone else. Question 16, what is the primary role of the team leader during a resuscitation effort? Is it A, performing chest compressions, B, assigning and coordinating team roles, C, administering medications, or D, managing the defibrillator? All right, what is the role of the team lead? Revealing the answer in 3, 2, and 1. Yes, it is B. The team lead ensures clear role assignments and effective coordination during CPR, during resuscitation. Question 17. What is the appropriate dose of epinephrine during cardiac arrest? Is it 0.5 milligram IV or IO? Is it 10 milligrams IV or IO? And I do apologize. The first one said every 5 minutes. B is 10 milligrams IV or IO every 3 to 5 minutes. C is 1.5 milligrams IV or IO every 10 minutes. And D is 1 milligram IV or IO every 3 to 5 minutes. Let's see how well you know your ACLS drugs, because you just can't say, hey, give them epi. You have to tell them how much epi to give. All right, revealing the answer. 3, 2, and I am so proud of you. Congratulations. You got that right. You rock. It is D. You're going to give a dose of epinephrine, 1 milligram IV or IO every 3 to 5 minutes. And again, a rule of thumb is you'd administer it every other cycle. Question 18. A patient in cardiac arrest has muffled heart sounds, distended neck veins, and hypotension. Which reversible cause is most likely? Is it A, cardiac tamponade, B, pulmonary thrombosis, C, toxins, or D, hypothermia? Muffled heart sounds, distended neck veins, and a low blood pressure. Revealing the answer in 3, 2, and you got it. Cardiac tamponade. You can't really hear the heart because the pericardial sac is surrounded with fluid. So therefore, we have those muffled heart sounds. So cardiac tamponade presents with classic signs such as Beck's triad. That would be the muffled heart sounds, distended neck veins, and the low blood pressure. It requires immediate pericardiocentesis. Question 19. Which rhythm is non-shockable? That means it cannot be treated with electricity. Is it A, ventricular fibrillation, B, pulseless electrical activity, C, pulseless ventricular tachycardia, or D, torsades de pointes? Process of elimination. Which one did we not talk about during this video on shockable rhythms? All right, so revealing the answer in 3, 2, and yes, it would be PEA. So the answer is B. Pulseless electrical activity is non-shockable. It is actually, there's an organized rhythm on the monitor, but for whatever reasons, those H's and T's, you cannot feel a pulse. Therefore, we call it pulseless. So let's say a person bled out because of an auto accident, or maybe they had been shot. Now, the heart still has electricity, but because there's no blood, you're not going to feel a pulse. So whenever we have a non-shockable rhythm, such as asystole or PEA, we have to get to those H's and T's right away in order to save this person's life. So in that particular scenario, we'd be considering hypovolemia, and we would start dumping blood products and fluids because, again, as of right now, the heart still has electrical activity, but there's not enough blood flow to support cardiac output. Question number 20. Why should medication be administered during a cardiac arrest if IV access, how should medication be administered during a cardiac arrest if IV access is unavailable? Is it A, delay medications until IV access is obtained? B, administer the medication via the intramuscular route? C, administer medications via endotracheal tube? Or D, use the intraosseous, the IO route? And everyone has it right. I am so proud of you. It is D. And so there's an image there of, it's like a drill. And this was actually started in the military. The military was the first to use the intraosseous devices. And so the IO route is recommended for administering medications if IV access cannot be quickly established. And so this medication would be administered directly in the bone, in the marrow, and that's how it's going to travel throughout the body. And so some resistance is normal whenever you are administering IO medications. And guess what, team? Don't forget to download our free study guide at ffellotraining.com. And I'm so proud that you chose to study with us ACLS on bright and early on this Sunday morning. And so thank you all for watching. This evening, I'll be back with a CNA video. I'll be posting information about that shortly. And so if you have any questions, you can put them in the chat. I'll be monitoring it for a little bit. Have a great day, everybody.